Okay, good morning, everybody. You represent the hardcore of PMAC, clearly. So congratulations to all of us for being here on the last day, on the Sunday morning. But we'll try and wake up with some stimulating examples. My name is Doug Webb. I'm from the health group in UNDP in New York. And thanks to the PMAC Secretariat for allowing us to host not one, but two sessions today, looking at the interactions between health sector and climate change, the impact of climate change on health, the response of the health sector, and in an area which is extremely new, generally speaking. There's a lot of piloting, a lot of modeling, a lot of experimentation going on across sectors and actors which I think traditionally have not worked together. So I'd like us to sort of think about the roles of institutions, the roles of constituencies, how these work in an ecosystem of action, which is extremely new and novel. So with that emphasis on learning and identifying essentially the co-benefits of this interaction in an area where traditionally co-benefits fall between the objective sets of different institutions. So how do we identify those co-benefits and action them in terms of investment and collaboration when we know that the value of the health benefits of climate change mitigation has the potential to offset most of the initial mitigation costs? So the reliance on understanding the value of this interaction and collaboration is actually fundamental to its investment in the first place. So we want to explore in this first session on mitigation, the leverage points, the financing mechanisms, the collaborations needed to mitigate climate change, promote human health and well-being, and secure environmentally sustainable healthcare practices, while looking into the broader auspice of equity and justice, and how does all this collaboration increase attention and support to the most vulnerable groups. Whenever there's a novel interaction or a novel model of activity, very often inequity is not included in the design, and inequities can actually increase in the initial stages, and then there's this process of, oh, we've left people behind in this activity. So we've got presenters today in discussions from Thailand, from Japan, from Ethiopia, from across the region, and then a perspective from the UK. So without rambling on too long, I'm going to ask the first speaker to come up, and that is Wijan Samachaya, who's the chairman of the Thailand Environment Institute and the acting director of Environmental Network and Climate Change Program here in Bangkok. So welcome, Wijan.
Distinguished participants, ladies and gentlemen, good morning, everyone. It's my great pleasure to be here, especially to share my experience and knowledge on environmental issues, especially related to the health today at the Prince Mahidol Award Conference 2023 today. Environmental issue, especially right now, we are facing with the impact of climate change, pollution problem for both transboundary issue or even national issue. Like Thailand, currently we are facing with the PM 2.5, especially in Bangkok metropolitan area and the northern part of Thailand. I'm going to give you some information, especially for the policy, how we develop policy from global policy to national policy, and also some example how we implement the policy on the ground level. You can take a look similar to other countries around the world. Thailand, by our Prime Minister, already commit at the COP26 on the climate change. Thailand set our emission target for the reduction of the greenhouse gas emission. We are going to have like a carbon neutrality by 2050. That's the only carbon dioxide. But for the long-term target, Thailand going to have net zero greenhouse gas emission, including all greenhouse gas, for example, methane, nitrous oxide from agricultural activity as well by the year 2060. But for the short term that we are already commit in Paris Agreement for the year 2015, that Thailand going to reduce greenhouse gas emission by 20 to 25%. We can do ourselves at the 20% compared to our baseline formation, but we can do more if we can get support from international agency. But for the COP26, our target for the year 2030 has changed from 20 go to 40, but based on international support. You can take a look here. Thailand in the year 2018, we developed Thailand long-term greenhouse gas emission development strategy for the country. You can take a look activity and incorporate with the long-term target. For example, for the year 2030, we plan to reduce 40% of greenhouse gas reduction. But for the year 2035, we plan to use the electric vehicle at about 70% of our current vehicle right now. But for the year 2037 is the long-term national strategy that we are already set up. Thailand going to have green area, 55% of the area of the country. At that time, if we can get our target, we can for the carbon dioxide level at 120 million ton carbon dioxide equivalent. Currently, the country emit greenhouse gas emission at around 354 million ton carbon dioxide. That's why we have to set very ambitious target. But for the long term, at the year 2050, renewable energy will replace the petroleum-based energy source in the country. But for long term, 2065, we're going to have our net zero greenhouse gas emission as target I mentioned earlier. Government also set very ambitious national agenda we call BCG. Bio, B stand for bioeconomy, C stand for circular economy, G stand for green economy. Biodiversity is the Thailand breed of the biodiversity. Actually, we are the top 20 country that we lead with the natural resources and biodiversity. The agenda look for how we utilize our natural resources with using the science, technology, and innovation that we can use less our resource. At the same time, we can protect the resource as well. Circular economy also come since right now we are facing with the pollution problem like waste. Thailand generate waste annually around 28 million tons a day, but we can recycle only few of them, especially plastic waste, also national agenda, also international agenda as well, how we dealing with it. That circular economy can be applied for that green economy. That's also very important issue. For example, for the BCG in circular economy, we select the issue that can benefit to the other activity, for example, plastic waste, and also the food waste, food loss, also very important issue that link to the health of people in the country as well. This is some example how we can apply circular economy, public-private. Very important how we can get them involved. Here, just example of the project we call PPP Plastic Public-Private Partnership on Plastic Waste Management. This also support national agenda, also support SDG development goal as well. This is our partner to work on the plastic pollution for the country. In our ocean right now, we facing with the microplastic contamination in the food. Just why plastic pollution also very important issue. Here, just give you an example. If you would like to know more, you can talk to me later on. That how we can apply the circular economy for plastic and waste management in the country. That's the support roadmap of plastic prevention as well. Here, how we develop the policy, I think is very important. If we can get one policy can support like a co-benefit other activity as well. For example, for the plastic waste management, support national roadmap on single-use plastic prevention. At the same time, also support the ASEAN framework on protecting marine plastic debris, support national agenda on biocircular green economy, support SDG. At the same time, the cropping with the greenhouse gas reduction and health impact as well. Another example we call Thailand Business Council for Sustainable Development. This is also a group of the private big company in Thailand join to work together. You can take a look organization that joy we call Thailand Business Council for Sustainable Development, linked to World Council for Sustainable Development in the country. I myself also serve as Secretary General of the organization. Yeah, the issue that we are working support the government policy, for example, how BCG can come be action in the country. Plastic waste, I mentioned earlier, climate change, also very important issue. PM2.5 currently we are facing in Bangkok metropolitan area, and the new agenda that we are working right now is the biodiversity loss with our partner. Also, we have like a network we call Thailand Carbon Neutral Network that working on the how we can go to the target that since Thailand already set the net zero greenhouse gas emission, how we get there. A lesson learned from the company can share with other company as well. We have TCNN Thailand Carbon Neutral Network right now. We have member roughly 300 company join that activity. When we talk about the national environmental issue, I think it's very important. especially regulation enforcement in the country. For example, for PM 2.5, right now Thailand revise our national standard to be incorporated with the health impact of the people in the country. For example, annual standard not exceed 15 microgram per cubic meter for the past. That figure is around 25 microgram per cubic meter, but right now we reduce our national standard to go with the WHO guideline for 24 standard, also from 50 reduced to 37.5 microgram per cubic meter. We also have the plan that we call Environment Health Action Plan, work closely of the Ministry of Natural Resources and Environment and also Ministry of Public Health, work together to set the plan how environment linked to the health impact of the country. Currently, we have new regulation we call the National Control of the Occupational Health and Environmental Disease Act, the year 2019. PM 2.5 already announced as a disease that have to control, have to investigate, have to look for the source of pollution, something like that. That's an example. The research of the country also support, especially when people talk about PM 2.5, how we can measure PM 2.5, like monitoring system set up in the country, why people have to take care of the health of community. Right now, we have almost 1,000 portable PM 2.5 measuring in the country. And another project work on the climate change issue. We call success that the objective of the project is strengthening the urban climate governance, including the resilient sustainable society, how local people can get involved, especially on the issue of adaptation. Here, show you activity that we work with the community in the southern part of Thailand, in the northeastern part of Thailand, that environmental issue and geographical is different, that lesson learned from community can share to other community as well. That's the project, local based. And the important issue is the how we can get the youth in charge of our project. I think it's really important when we talk about climate change. It's the long-term impact, how youth, students, and children can get involved. Right now, we also have a project we call Youth in Charge on the climate change, youth in charge in the BCG, or even BCG in action. With that is my conclusion of my presentation. Thank you very much.
Thank you, Wijan, for getting through a very complicated model and arrangement that you've created here in Thailand. And I mean, also, my questions really would be around, what are the different incentives of the different actors in this quite complicated system that you've got? You've got a lot of private sector partners, a lot of public sector partners, community engagement. So how do they, come to the table, and what drives their action? And, there's that model of interaction, I think, that we're most interested in. So thank you, Wijan. We'll come back to you a bit later. So we're going to move westwards to Ethiopia. I hope Germa Gemechu is on somewhere in the room, in the sky. Is he there? Okay. So Germa is the Director General of the Environmental Compliance Monitoring and Control Directorate in the Environment, Forest and Climate Change Commission in the Ethiopian government, and we've been working with the Ethiopian government on looking at the issue of air pollution. So Gurma is going to just go over what's going on in Ethiopia. Gurma, good morning. We understand in Ethiopia it's very early. Apologies for that. Welcome.
Thank you. Thank you very much, Douglas. Ladies and gentlemen, colleagues and friends, good morning from Addis Ababa. My name is Girma Gammachu, and I'm Director General for Environmental Compliance and Enforcement in Environmental Protection Authority. I will take you through the Ethiopia's effort to integrate health, climate, and air quality management in a coordinated approach. To begin with, the climate change and air pollution now becoming a challenge for Ethiopia, including other many developing countries. If we take air pollution alone, it is the leading environmental risk factor for premature deaths globally. According to the World Bank report in 2019, indoor and outdoor air pollution was estimated to have contributed 6.7 million deaths worldwide. This is nearly 12% of the global total. The health impact of air pollution are also reflected in morbidity level, loss of income, decreased participation in the workforce, disability, and higher healthcare costs. For instance, according to the World Health Organization, and health environment account for almost 25% of all deaths globally, accounting 30 million deaths annually. Air pollution causes and aggravates many diseases, ranging from asthma to cancer, lung illness, and heart disease. According to the World Bank again, the non-communicable diseases accounted for 43% of all deaths in Ethiopia in 2019. Having said this, as we all know, the problem of air pollution cannot be solved solely by the environment or the health sector. Solutions need to be coordinated among several stakeholders. In Ethiopia, key stakeholders include, for instance, the Ministry of Health, the Environmental Protection Authority, the Ministry of Transport and Logistics, civil society organizations, UN agencies, and communities. We aim to improve communication and coordination between these entities to mitigate climate change, reduce air pollution, and non-communicable diseases without compromising the economy. In this context, I would like to speak about the projects that Ethiopia is currently implementing with the support of the United Nations Development Programme. The project is known as Advancing Health and Environmental Sustainability Through Action on Pollution. It's funded by the European Commission and implemented by UNDP globally and in 3 countries, including Ethiopia. Since the beginning, in 2020, the project has been bringing together sectors address the health impact of pollution. The project has 4 basic objectives. The first one is to develop and pilot methodology to calculate non-communicable disease-related health costs of inaction on pollution, as well as the return on investment in selected cost-effective and nationally prioritized intervention. This is what we call a pollution investment case. The second objective of the project is to enhance governance and coordination across the environment, health, and other relevant ministries to enable joint action on pollution in collaboration with civil society and private sector. The third objective is to advance effective laws where we lack a lot of things. So this objective aims to effective policies, standard, and regulation by developing a tool that allows assessing the health and the pollution legislation. This is expected to lead to a strengthened parliamentary and civil society action on pollution to mitigate the impact. The fourth objective of the project is aim to share these new tools and results regionally and globally by hoping other countries, including low-income countries, will benefit from this. The Ethiopian Environmental Protection Authority, in collaboration with the Ministry of Health, in the process of piloting the investment case and legal environmental assessment tools to improve the government of pollution and better health outcomes. So this is the finding we have known so far. According to the preliminary finding from the ambient air pollution investment case, ambient air pollution is responsible about 10% or 11,500 deaths caused by 5 non-communicable diseases. As you can see from the graph, the total deaths is 11,500, but only 5 non-communicable diseases are contributing for this. The total economic burden of ambient air pollution was estimated to be about 433,000 in 2019. This is representing 0.5% of Ethiopia's 2019 GDP, and it is equivalent to 3.9% of per capita cost. The primary cost driver is premature mortality, which accounts 95.8% of the total economic burden. The other thing I would like to mention is the direct health cost and productivity loss due to absenteeism is account for 0.4 and 0.5 of the total economic burden respectively. This is what we are now communicating to the key stakeholders who are involved in it to them to enable, allow resource to enable them to go through the policies, standards, and laws for the betterment of the environment. The other thing in this project, we have gone through revising our legal environment for the betterment of the health and the improving of well-being of human beings. So the primary result from the legal environmental assessment on health and pollution, the finding shows that Ethiopia's current laws, policies, standard, and guidelines do not adequately address diseases caused by air pollution. The other thing, non-communicable diseases caused by air pollution are not recognized as public health issue in Ethiopia's current health policy. Ethiopia's health policy is the main policy which is mainly focused on health outcomes, but it lacks in addressing this basic issue. The other finding we see from the assessment, public health legislations contains no provisions for managing both indoor and outdoor air pollution from various sources. The other finding I would like to share with you is the National Hygiene and Environmental Health Strategy, which is effective document from 2016 to 2020. The situational analysis of indoor and outdoor air pollution problem was not considered in that strategy. The 2020 National Transport Policy makes no mention of quality of diesel oil or inspection of vehicular emission levels. Instead, it's focused on greenhouse gas emissions. And the 2011 building regulation did not express the control of air pollution during building construction and demonstration, which the majority of cities now facing a higher amount of PM 2.5 and PM 10. So this and other identified gaps in legal environmental assessment will be addressed both the current and future policy and strategy revision. The other thing I would like to share with you is to address the challenge of or work on the mitigation. We have a project called Deep Dive Project, which is a UNDP support program, which aims to contributing effort for Ethiopia's national determined contribution implementation. This support Ethiopia's updated, as we all know, the Ethiopia's updated non-communicable the National Determined Contribution Implementation Roadmap from 2021 to 2030 includes interim and final NDC target for 2025 and 2030. In this plan, we aim to reduce emission by 69% with our own funds and 69%. For this action plan, totally we require 360 billion of USD, of which 63.2 billion will be covered by our own, and the remaining will be mobilized from international donors. Sectorial line ministries, including the Ministry of Health, have developed a roadmap for implementing climate mitigation initiatives that are anchored in 10 years perspective plan. I will come to the major issues addressed in 10 years plan, the next slide. This 10 years perspective plan is another flagship program which deals climate change and mitigation and adaptation. It is a pathway for us to prosperity. We are expecting 10.2 annual economical growth, which is supporting the climate mitigation, the climate economy. The CRG, which is our long-term strategy, it output an effort to boost farm productivity, basically planting shades, trees among coffee plants, and spreading solar energy across the country for regenerating 22 million hectares of degraded forest by 2030. The Ethiopia is currently focusing on the energy issue. Of course, we have approximately 4,500 megawatt of installed energy, and we using the natural opportunity that we have, we are working to increase this and improve access for energy. So the government is working to provide reliable energy access to all. This will come with health impacts such as hospitals being able to better treat patients and less health burden from indoor pollution. Lastly, Ethiopia is working to replace gasoline-powered vehicles with electric vehicle. In this regard, the country has exempted electric vehicle from VAT, excise tax, and surtax, as well as reduced the import tax. Ladies and gentlemen, colleagues and friends, with this, I will conclude my presentation and look forward to productive discussion. Thank you.
Thank you, Goma. Thanks very much, and thank you for being there so early in the morning to explain what you're doing. And you really are, in a sense, at the start of a very long road, it seems, in defining the costs, their distribution, looking at legislative environments, and being innovative in terms of policy and laws. So I think it raises the question of how do countries learn from each other and these models when you've got one country setting off on the road, another country which is already 5-10 years into experience. how do the countries share that experience to learn lessons quickly? South-South Triangular cooperation. So Goma, thank you. We'll come back to you. Next, we're moving back east to Japan. Keisuke Nansai is a research director at the Material Flow Innovation Research Program at the National Institute for Environmental Studies in the government, looking at the drivers, demands, sources of healthcare's carbon footprint. So welcome.
Yeah, thank you very much. Your pronunciation for my name is perfect. Thank you very much. Anyway, good morning, everyone. I'm Keisuke Nansai from the National Institute from Environmental Studies Japan. So today, I'd like to talk about the structure of the carbon footprint of the healthcare, especially the focusing on the Japanese situation. Could you go to the next slide, please? So, as you may already know, so carbon footprint include not only the direct GHG emission from the hospitals, but also the indirect emissions that occur through the supply chain required for healthcare activities, which is shown in the illustration. You can imagine how they are connected in the economy. Could you go next slide, please? Oh, sorry, I should operate by myself, sorry. So this graph shows the amount of the environmental burdens generated by global healthcare demand, including GHG emission, the primary PM2.5, NOx, anyway. If we look at GHG emission here, we can see that healthcare generated 2.4 gigaton of CO2 emissions in 2015. This corresponds to 4.4% of the total global GHG emission. So these pie charts show how much more GHG emissions will be allowed if the temperature rise is kept below 1.5 degrees. It's called the carbon budget. When we check the carbon budget, so the carbon budget is only the 380 gigaton in 2022, last year. Here, let me do some very simple calculation. This 380 gigaton is allocated to the healthcare sectors according to their current emission share. As I introduced, healthcare accounts for 4.4% of the total emission. Therefore, it means 16.72 gigaton is available for healthcare. But now the healthcare carbon footprint is 2.4 gigaton per year. Due to the simple calculation, if this emission level continues, this carbon budget for healthcare will be used up in another 6.97 years, about 7 years. So, as introduced by our first speaker, so the Thailand is going to the carbon neutral. That's why here we can assume the healthcare, global healthcare, will be carbon neutral by 2050. At the time, the carbon budget will need to be used up in 27 years from now instead of just 7 years, 6.97 years correctly. To do this, on average, healthcare would have to lower its carbon footprint to 26% of the current level. It's almost a quarter. It's it needs a very dramatic change. So let me introduce the Japanese situation of the healthcare. The carbon footprint of healthcare in Japan was 16.5 megaton. It's accounting for 4.6% of the total GHG emission. It's very similar to the global share, I have said. But the direct emissions from healthcare or just the 8.5 megaton, not just, sorry, the 8.5 megaton. So you can see how significant the emissions through the supply chain are. Emissions from healthcare services, including hospital patient and outpatient visit and medication, account for 66% of the total footprint. However, here I'd like to emphasize, so through the fixed capital formation in the green part in this graph, including hospital construction and production of the medical equipment, also account for 14% of the total. It can't be ignored, it's not negligible. So this graph shows the trend of the carbon footprint of the healthcare in Japan. As you can see that the size of the footprint does not change year to year from 2011 to 2015. It implies without strategic reduction measures, it won't decrease, much less by a quarter. To significantly identify intervention points for reduction, the carbon footprint can be decomposed structurally in three perspectives. Here, let's assume that the carbon footprint from healthcare service is 50 tons for simplicity. First, at the left side, you can see the idea by decomposing by demand. Knowing which disease causes the healthcare footprint, we are able to know which diseases are beneficial for carbon footprint, for carbon reductions, to reduce the occurrence of the diseases. Then, if we decompose by driver at the middle of this graph, we can see the relationship between what healthcare purchases and carbon footprint occurring. But as you can imagine, even when medicines are purchased at the healthcare at the hospital, the actual carbon emissions are occurred at the pharmaceutical companies, at power plant, and at the resource extraction site. Therefore, looking at the emissions by emission sources, it's possible to understand where the 50-ton emissions actually occur. So I'll show you the example of the Japanese case, in terms of decomposition of the carbon footprint. The carbon footprint of the healthcare services is now broken down by diseases. So in Japan, as you can see the diseases with the hand mark here, the contribution of treatment to cardiovascular, respiratory, and cancer diseases is significant in terms of the carbon footprint of the forming. So this graph is a little bit complicated, but the graph on the left side they show the contribution of the top 10 drivers of the carbon footprint of the medical services. Driver is a commodity which the health sectors purchased. So as you can imagine easily, there are pharmaceuticals and also electricity and on-site emissions that account for the half, 50%. The other half is generated by the use of trading company. This is very Japanese, how to say, customizing the medical services. The transport and cleaning services and waste disposal services. The purchasing those products, the direct of the half of the carbon footprint. And the right-hand side graph illustrates in which sectors the emission actually occurred. The electricity generation accounts for 1/3. Currently, so renewable energy generation, including the PV and wind power, and electric vehicles are very much expected as decarbonizing technologies. But the sectors in green are those where the emission can be reduced by such the renewable and EV technologies. However, the sectors in black letter here will not reduce emission with even though introducing those technologies. It's very hard to mitigate. The same decomposition technique is applied to the carbon footprint of fixed capital formation for healthcare. The main drivers of carbon emission are construction of hospitals, the production of medical equipment, and the purchase of the motor vehicles at the hospital. The sectors that actually produce emission are the power generation, so pig iron steel company, and cement production. You can imagine that they are related to the construction of the hospitals. You would notice that there are fewer green letters compared to the previous slide. Emissions from the fixed capital are unlikely to decline on their own at sources itself. So, sorry, I timed up. So I would like to summarize my slide. But this table shows that intervention stakeholders and the primary target and the policy measures by the drivers and demand driver and sources, as I said. You can look at maybe the letter is tiny, but if I can pick up one point, I'd like to mention about the last part, I mean the sectors, of course, because the demand and the drivers can be tackled directly from the healthcare sectors from tomorrow. But I think the most important thing is how the healthcare sectors intervenes at the sources, emission sources. For example, I would say it's vital to move society toward the planetary health by, for example, forming net zero alliances between the healthcare sectors and industries. They are connected indirectly. It's very hard to intervene directly, but therefore, first, making such alliance would be, useful, especially on the material industry. As I said earlier, steel, cement, and chemicals are very hard to mitigate. Yep. So I'd like to conclude my slide with these key message. Yeah, thank you very much.
Thank you, Keisuke. Very, very interesting, and I hope we've all remembered all those statistics you've put on the screen there. My initial response is that looking at the health conditions which are driving the carbon emissions, the cancers, the CVD, and the respiratory infections, we don't, when we look at our return on investment calculations in disease reduction, ever consider the carbon emissions. They're just not part of the equation. But it looks like these are significant questions that we need to address. And then understanding how prevention of these diseases is actually then going to be a contributing factor to a reduction in carbon emissions itself. So when we're looking at universal health coverage and the expansion of the health sector, very often that will be a carbon problem, in a sense, where if it's not designed. And looking at the situation in Pakistan, the recovery efforts there, the reconstruction of the health system in some places, and eventually the loss and damage fund, how that's designed. The worry is that actually, if it's not designed properly, we could actually have a negative impact on carbon emissions. So these kinds of calculi, I think, are very helpful in understanding the relationships between the disease and the systems and the investments that are required. So thank you for that. Okay, we're going to look at the Southeast Asia more generally now. Ramon San Pascual is the Healthcare Without Harm Executive Director for Asia, who's going to look at the healthcare without harm experiences on supporting the work around greening of the health sector. So Ramon, welcome. Thank you.
Thank you, Douglas. Good morning, everyone. Good to be part of this last day of the session in the 2023 PMAC. As Healthcare Without Harm Executive Director for Southeast Asia, I was given the task, and I wish my slide can be shown already. All right. On how we do it in terms of mitigating the healthcare carbon footprint, and I'm glad that I'm following it up after the earlier presentation on Japan's carbon footprint, particularly on the supply chain. Now, I'm based in Manila, and the Philippines is right across the path of big typhoons that have happened over the past 10 years, at least in our region. The one that you're seeing now is the Yolanda, or what we call as the Typhoon Haiyan globally. That's an international name. In itself, it has damaged 432 healthcare facilities. And then in recent year, not even 2 years ago, this is Typhoon Rai that has impacted many communities in the south of southern Philippines. And what you see there in the picture is the Caraga Regional Hospital in Siargao City. And I think we're blessed to have the city mayor of Siargao in the room. I hope he can share later. But just to prove the point that climate disasters threaten the capacity of the healthcare systems and facilities to sustain the very services that are meant to treat people from diseases. In the case of this Siargao Regional Hospital, it happened at the peak of the pandemic. And there are 200 inpatients at the time, and many of them are with our COVID patients. And yet, hospitals, as shown, emit carbon and toxic emissions that seriously threaten both our climate and the environment. It is the fifth largest country in terms of emission if we consider the 4% emission coming up from the entire global healthcare sector. That's significant. Now, in the COP26 in Glasgow, there were commitments made on climate resilient and sustainable low carbon health system. On one hand, just like in our region, we should be more concerned about adaptation and resilience measures being taken care of by the communities as well as hospitals. But for the purpose of the discussion this morning, I will focus more on the sustainable low carbon health systems, how it is being done in our own region in Southeast Asia. To attain sustainable low carbon health care, it would always require cross-sectoral interdisciplinary collaboration, not at the global level, but more so at the country and local level. And this is what I'm trying to emphasize on as we proceed with the succeeding slides. For those of you who joined the tour before the conference, there is one that the site is the Chakri or the NMCI or CNMI in short, which is also part of the Mahidol Medical University. And we saw there the solar energy that they have installed, quite a large amount already that has been being supplied by renewables through the solar panels installed across several roofs of the several buildings in the entire large campus. Now, if we talk about solarization in hospitals, what we observe normally is that private companies would offer a no cash out kind of an agreement to the hospitals, which the company would run for the next 5, 7, 10 years, depends on the agreement, and after which it will be turned over fully to the hospital already paid up. But in the course of running at the day one, the moment it is installed, solar panels will already save a huge amount. In our case, in the Philippines and certain hospitals in Indonesia, it would be about up to 10% savings right away on the year 1 up to year 5 in terms of the hospital bill. And you can imagine how much it is as well in terms of the carbon footprint. Now, apart from the what I shown earlier, which is the low carbon energy in the hospital, which is not really a big challenge to do, but I think it's more the policy that constrains hospitals in some places, in some countries in our region. In some hospitals are ready for carbon emission measurement, but the help in terms of tool development is not there, and therefore this is where we see partnership with universities, NGOs, and even government agencies would be critical. Partnering with those who know how to manage data and analyze data and install them in this data system in the hospital will be critical to obtain a sustainable low-carbon energy system in the hospital, even by means of solar panel. Now, the next slide, I think I'm moving forward too fast. Wait. Oh, I haven't shown this, the transportation. Now, the other thing I've got, I was really impressed by this field trip. I've seen many green hospitals across the region and even in our own work in other regions in Healthcare Without Harm. But transportation is one best way to reduce carbon emission within the facilities, within the healthcare facilities, simply because this is a transportation-intensive industry, whether by ambulances, hospital vehicles, delivery vehicles, staff and patient travel. How do you deal with the transportation inside big complex or big systems of healthcare facilities? This is what is shown in that trip, in that tour. They are ready with around 2,000 bikes in the campus that they are made available both to the staff and to the medical students, even to the doctors, just crossing buildings. For 10 baht, if I remember, for the first 30 minutes, and then, for the first 30 minutes, and then 30 baht, 10 baht after every 30 minutes, then on. Then students and medical staff are provided the easy means of moving around, at the same time promoting healthy lifestyle. It is a green campus, so it's quite convenient to cut across buildings shaded with trees and well-paved road. So hospitals who take up transportation as means of reducing carbon emission, and there are few of them yet, need the support of private vehicle suppliers, financing institutions, city planners, and officials, as much as the leadership in the hospitals. In the more advanced experience I have seen in Seattle Children's Hospital, first of all, they gave away bikes to every staff. Second, they measure the mileage and make it part of the performance evaluation of the medical staff. Third, they have right inside the facility, they have the repair shop free for bikes. Fourth, they link the biking lane with the bus systems. So how does it happen would really mean collaboration, not only within the healthcare system, but among the city planners as well. Moving on, here I want to show another way of reducing carbon footprint in the hospital is by building parks and green spaces within the facilities. And this is the Kotik Pot Hospital that is able to, by providing greeneries and deliberately planning for making it a park, hospital as a park and park as a hospital, they're able to capture carbon, reduce heat, and facilitate natural cooling, and foster a sense of community within the large campus of the facility. Because it is a park, people go to the hospital not to be treated, but to meet friends and have coffee. This is the Kotik Pot Hospital that has hosted us in 2019 for the Green Hospital Asia Conference. If you note there, it harnesses the power of nature in healing. By providing the natural cooling into the building where patients are confined, they make use of the natural wind and the window system to ensure that healing is facilitated together with the lighting system as well. And then if the patient would walk out, they see a garden across not only ground floor, but across the floors. And on the top floor, on the roof, they're able to yield gardens that are yielding vegetables and trees, fruit trees, which are sold to the public in the hospital, as well as served in the cafeteria, being as food both for the patients and the visitors. Now, in the next slide, you would see, therefore, that Kotik Pot in Singapore has designed their building with a special layout that provides good access to natural light, rooftop garden that reduce urban island effect, and therefore create an impact in terms of reduction of energy use, and they're making them very efficient energy utilization wise. Now, the other way of reducing carbon footprint in the healthcare is the recent experience on COVID. And I've been part of a project launched by the ADB on green vaccination. And you would see here how, again, with the mentality of sustainability and reducing carbon footprint across the provision of vaccine in Southeast Asia, and these are the lessons that were learned. There's the need to strengthen coordination between global health donors, logistics or companies, healthcare waste private sector holder, the need to regulate waste management, the need to invest in safe, resilient waste management system, including, rather than relying on PPE as a protective gear throughout the day for every doctor and nurses within the facility, why not improve the wash facility inside the hospital? A simple soap and water with the provision of the facility in the facility of the different means by which you can wash your hand regularly, free you away from this very uncomfortable wearing of the PPE throughout the day. At the same time, free up the environment with the disposal of the plastics. Every time gloves, a mask, or even the entire body wear is disposed of every time it is worn out. Adoption of reverse logistics. So what we're trying to point out here is that in every operation of the healthcare system, there is a means by which we can reduce our carbon footprint. Let us look at food. This is now the West Java Mental Hospital in Indonesia and the Buddhist Chuchi Dialysis Center in Malaysia. Both are into food production. Both are into nutritious food serving their own patients. And this is in the case of Chuchi in Malaysia and also in Taiwan, they promote plant-based diet. In the case of the West Java Mental Hospital, they made sure that their land were productive during the COVID time by initiating a local organic farm with community farmers. And therefore, by so doing, again, you capture carbon. At the same time, you lessen your dependence on meat that are also heavily emitting industry. Now, let me now go macro a bit, and this has been reported by citing, therefore, how do we track and how do we ensure that indeed the healthcare system, the entire sector, is along the path laid down for us by the UNFCCC. This is the Global Roadmap for Healthcare Decarbonization, which we launched 2 years after the study that we made on the carbon footprint of the healthcare system. That was 2019, and this was, I think, in 2021, already in the COVID. Now, we relate the healthcare sector with the entire society. That's one. We don't isolate ourselves from the rest of the burden that all of us have made why we are at this point of the climate crisis. So if the health sector around the world were to come together, it could influence more than its own footprint. That's what we believe in. Healthcare as an anchor of resilience in the community. If we model that, there's a large influence that we can make, even among the private sectors, among the residents, among the local officials. If healthcare development, growth, and investment can align with the global climate goals, the sector could help provide leadership for a low-carbon, climate-smart, and more equitable and healthcare future. So the call is not only on mitigation, not only on adaptation, but on leadership development among healthcare people, among doctors, among nurses, among engineers working in the hospitals, among those in the laboratory, to be aware of climate and to speak it up and show it how they work it out within their respective roles in the hospital. That's leadership. The roadmap for healthcare decarbonization provides a plan and charts a course to get healthcare towards zero emission. And this is the last part of my presentation on the not moving. Okay. Now the chart here shows to you how far we can go in terms of moving to zero emission up to the 2050. There are several pathways, and I will not discuss each one of them, but enough to say that there is a roadmap that hospitals can follow in collaboration with the rest of the society. And the next chart are the 7 high-impact actions, how to reduce the entire world greenhouse gas emissions, and how healthcare sector would play a role. Now, when the Race to Zero was launched in the UNFCCC a few years back, Healthcare Without Harm was made a partner in terms of aligning the healthcare sector with the Race to Zero target. This is along with other sectors such as cities, mayors, politicians, policymakers, regions or countries, business leaders, investors and bankers, universities, and then us in the healthcare sector. Therefore, moving to zero would mean collaborating with the rest of the society, even if we are taking care of our own hospital members within the global green and healthy hospital network. Now, in March or April, we will consult with the first batch of hospitals in Southeast Asia that had enlisted themselves on Race to Zero. You see the 6 names there so far. I hope that it will come out to 10 hospitals by April. But it is across the region, from Taiwan, from the Philippines, Singapore, Malaysia, The Sunway system is part of our Race to Zero hospitals, and then, of course, from the Indonesia. Now, the work is not only in the hospitals, and this is where I'm pointing it out. How about what the universities are doing? How about what the cities are doing? And how to collaborate with hospitals? How do we learn from one another? And tracking down some of the names, for example, in Thailand, there are 2 known universities that are also in the Race to Zero. In terms of cities and the mayors, there are those that are in Indonesia, in Palembang, in Bangkok, in Hanoi, in Quezon City, in my own, where my office is, in Malacca, in Indonesia. So the work now, therefore, is not only within the hospital, although we're trying our best to create the leaders and count and measure and reduce the carbon footprint in every way, wherein 70%, as said, is coming from the supply chain. And yet challenge the rest of the community to deliver and compare how we are doing it. This has just started, and we know that this will be such a challenge to work in the hospital and much more to collaborate with the business sector, with the universities, with the cities. And we have this foundation of over 1,600 members of the GGHH, or Global Green Healthy Hospital Network, across the globe. 2,000 of them can be found in the Asia region. So, yeah, this is a good morning. Thank you very much.
Thank you, Ramon, and thank you for also just pointing out the obvious, that one of the biggest carbon emissions from the healthcare sector is things moving in and out of facilities, people, commodities. Yes, please come up. And then it also raises the question then of, what are the mechanisms to reduce the inflow and outflow of things, people and commodities to the healthcare sector. And I'm thinking also of digital health and telehealth. And I think the green credentials of these of innovations like this are not necessarily captured in some of these models, or of what are the benefits, not just to reaching more patients and extending coverage, but actually reducing some of the inflows and outflows which you've described. So thank you very much. Our last speaker is representing the Wellcome Trust, Modi Mwatsama, and everybody's going to be hanging on your every word, Modi, about what does a funder look for? What in terms of the knowledge deficits, in terms of the financing priorities. So Modi, thank you.
Thank you, Doug, and thank you for the invitation to contribute to this panel of distinguished experts. So I'm going to be telling you a little bit about the Wellcome Trust and our new strategy, which is embarking on helping to put health at the heart of climate action. So my presentation is going to cover 2 parts. I'll briefly explain why it is we decided to prioritize climate change as one of the 3 strategic priorities we're focusing on, and then I'll tell you a bit about how we're planning to invest in this space. So if we go on to the next slide, please. So we embarked on this new strategy in 2021. Historically, the Wellcome Trust has been a research funder, and we're continuing to invest in discovery research. But under our new strategy, we're aiming to solve 3 of the world's global challenges: climate change, mental health, and infectious diseases. Diversity, equity, and inclusion underpin everything we do. And over the next 10 years, we're aiming to invest £16 billion to help solve the challenges we've identified. What's also new about this strategy is, in addition to investing in research, we're also going to be investing in the uptake of that research. So our institution now has a big policy team, a partnerships team, an advocacy and public engagement, as well as communications team, who are all helping us to achieve our mission, in addition to us investing in research. On to the next slide. So why have we decided to prioritize climate change as one of the 3 challenge areas? Everyone knows here now, in 2015, the Paris Agreement was adopted, in which provided a legal framework for all governments to commit to limiting global warming to 2 degrees through their nationally determined contributions, enhancing resilience and adaptation to climate change, and aligning sustainable finance to ensure the actions they'd committed to would be implemented. And we've had 2 really excellent examples of NDCs from Ethiopia and Thailand this morning. On to the next slide, please. So one of the reasons why we've decided to invest in climate change is because this slide shows the progress that we're making globally towards meeting the Paris goals under different scenarios. The policies and action scenarios, which is the worst case, is the current state of the world today, including all the commitments that governments have made in their NDCs and current policies and actions that are being implemented. And as you can see, we're not on track to meet the 1.5 degree target that governments have signed up to. We're currently on track to limit warming to 2.7 degrees. Even under the very best case scenario, if we look at both the long-term, short-term commitments governments have made, and also assume that every policy that's currently under in development or discussion to support climate change is then implemented and adopted, all that is still going to be insufficient to meet the global Paris goals. Today, we're at global warming levels of 1.1 degrees, and we've already seen the effects of that climate change through increased floods, droughts, fires that have been happening around the world. Ramon illustrated some of the typhoons in the Philippines that have been happening from the warming that is already there today. So we really need to take an increased step change in the action that is undertaken to implement, to meet the Paris goals and avoid the global warming that is on track to continue happening. On to the next slide, please. So this slide basically summarizes the type of the state of the current research and evidence base in the climate change in climate change. It was a systematic analysis undertaken by Lee Baring-Ford and colleagues, and what they did was they did a machine learning review of all the published literature published in English on climate change and health. And what they found from the graph on the bottom left is that the majority of the scientific papers in this area focus on the impacts of climate change, so really describing the problem. There's very few studies looking at the adaptation and mitigation solutions that are needed to tackle climate change. So that's another reason why we're thinking about investing. We've decided to invest in this space. We need more evidence on what the effects of the solutions are on health, on the economy, on society, in order to help make the case for action. The middle slide, the middle graph on the bottom, just gives an indication of where the literature that is available today currently focuses on. The majority of it is focused on high and upper middle income countries, and there's much less research on low and lower middle income countries. The sorts of interventions that can help us achieve mitigation in climate change, some of which have been described, include actions in the food, energy, transport sectors. And Ian Hamilton and colleagues undertook a study to look at what would be the impacts of achieving the Paris goals across 9 countries, which globally represent 50% of the world's population and 70% of the greenhouse gas emissions. So they looked at the impact of meeting the Paris goals on health outcomes and looking specifically at the food, energy, and transport sectors. And what they found was that meeting the Paris goals would result in 1 million fewer deaths from improved air quality, 6 million fewer deaths each year from improvements in diets, and a further 1 million fewer deaths each year from improvements in physical activity levels. So there's significant health co-benefits that can be found from achieving the Paris goals. And those health co-benefits will result in reductions in healthcare costs, which we've heard about today. The NCDs are some of the biggest drivers of healthcare costs in countries such as Japan. And then they will also, those avoided healthcare costs and wider costs to society through losses in productivity, for example, can help support the case for, those cost savings can help offset the costs of climate action, which to date are one of the barriers to progress on climate action. In emerging economies, additional sources of greenhouse gas emissions include burning of waste fuels, solid cooking fuels from solid fuels, diesel, using diesel and petrol, as well as municipal waste collection, particularly waste dumps in which organic matter rots. That results in methane emissions, and methane is a gas that's 28 times more potent than carbon. So again, there's significant benefits across the world that can be had from meeting the Paris goals. So on to the next slide. So how are we planning to invest in climate and health as the Wellcome Trust? Next slide, please. So as I've said, our mission is really to put health at the heart of climate action through mitigating against climate change to help prevent the climate-related health risks that result from global warming. And some of the ones below are some of the ones that result and have been discussed today, things like poor air quality, food and water insecurity from things like droughts, floods, increased infectious diseases, vector-borne diseases, extreme heat and weather leading to things like heat stroke, as well as the social impacts from things like migration, people losing their livelihoods, for instance, if they were farmers. So how are we planning to do this? On to the next slide. We have 4 goals in our climate and health strategy. The first is really about generating evidence for us to better understand what are the full range of impacts that climate change is going to have on people's health, both today and in the future under the different scenarios. And then also estimating both the burden of those impacts as well as the costs associated with them. Then we have a second goal to really understand what are the effective interventions to help adapt to climate change in ways that protect health. Our third goal is really about understanding what are the effective mitigation solutions to help both reduce emissions, reach the Paris goals, and also have health co-benefits. And the final goal is really about catalyzing a global community of policymakers, researchers, practitioners who are able to undertake the research in the case of the research community, but then use the evidence in the case of everyone else to help put health at the heart of climate action. So this is really a field-building goal. And I think the climate change and health community is very much at the beginning of its journey. So I'll just end with some examples of the ways we're planning to invest in this space, and we've already started to. Final slide, please. Good. Thank you. Examples of some of the activities and investments we've been making. We have funded the Pathfinders Initiative and Lancet Commission, which is really bringing together policy stakeholders such as city networks, as well as scientists to do a systematic literature review of what are the existing implemented climate change mitigation solutions out there, and what is the evidence that they're actually having an effect on both reducing emissions and improving people's health. They're also looking at grey literature and identifying case studies of good practice. And I'm sure some of the ones we've heard today will be featured in that. So it's going to be a resource for policymakers as they embark on implementing their mitigation plans to see what are the examples of implemented solutions and what have been the effects of those. We've had a funding call that closed at the end of last year to really help advance health-centered mitigation action. And the way that call was designed is to support transdisciplinary research that could be implemented to help advance a policy solution that is either in discussion at the point of being adopted or where additional evidence could really help advance its implementation. So it needed to be responsive to a live opportunity, and the research needed to be undertaken with policymakers, either advocates or people working in government who had demonstrated the need for this evidence to ensure that the evidence generation would be relevant to helping advance change. We also currently have a request for proposals. We're inviting advocacy organizations, campaigning organizations to submit pilot projects in which they're going to be campaigning for climate change and health action, and it can either be in the mitigation or the adaptation space. So that's another example of the way we're not just investing in research, but then also supporting the campaigning to help that evidence be more known and then used. As part of our tracking efforts, we're investing in the Lancet Countdown. We're also planning to support training and capacity building, both of the researchers, but then also of policymakers, to really help them better understand the nature of the problem and how we can collectively solve this. We're planning to look, we're currently also scoping in Africa, Asia, and Latin America, who are the climate change and health communities, both on the research, the policy, the advocacy side. What are the barriers to integrated action, cross-sectoral action, interdisciplinary research? How can we invest in those regions to help really advance this health-centered climate action? And finally, we're also currently developing our 5-year action plan for our climate change strategy more broadly. So we're open to ideas, hearing from the community, how can we help and collaborate together to solve this climate change program? We'll be recruiting a head of mitigation and a mitigation team in the next few months. So if anyone's interested in coming and working for Welcome, look out for some of the jobs we'll be advertising. And I'll end there. Thank you very much.
Thanks, Modi. Very good. So we've all got until Tuesday to get our proposals scribbled and the CVs updated. But also, I mean, pointing out the knowledge deficits and the underinvestment in the adaptation mitigation agenda, and also the fact that Asia really is the lead in this area. But it then raises the question of what do we know about other regions and the models that are going to be operative or viable in those contexts. So there's a lot of inter-country exchange, which I think you've talked to, which is going to be crucial for all of us in international organizations. I have a bunch of questions for the panel, but what I'm going to do is open the floor up to everybody here. So if you have questions, please, or comments, please come to the microphones, because I think we've got about half an hour left, and I want to maximize the opportunity for conversation. My questions really are around some of the, the integration challenges. How do we incentivize different actors to work together in this space when funding has been so siloed, and the transaction costs of collaboration are so high? And you've all spoken to this idea of co-benefits and unknown or undervalued benefits, and the relationship between the health sector and other parts of government and society. So it's a huge discussion, but we welcome contributions. So yes, please.
Good morning. Hi, my name is Tim Mastro with FHI 360 and a member of the PMAC International Organizing Committee. It's a terrific session. Thank you really very much for the scope of this. I have a question for Dr. Witjarn from Thailand. Thank you. I really enjoyed your description of sort of the very ambitious and very broad approach that Thailand's taking to a BCG, a biocircular green economy. In particular, you had a very impressive list of private sector partners that you were engaging here. Could you tell us a bit about the nature of the private sector engagement and how public-private partnership works in this context?
Okay, thank you very much.
Oh, okay. Anne, good morning, Anne. So what? Welcome, Anne.
Thanks. Anne Mills, London School of Hygiene and Tropical Medicine. I'm a novice in this space of climate change and health, but there is a very long history of attempts at multi-sectoral collaboration, whether multi-sectoral in the general sense or coordination and common action against government. Long history in the health sector of struggling to get multi-sectoral action. And I wanted to pick up Doug's point about, well, what are the incentives? What are the things that might stimulate that? And I was interested in reflections from any member of the panel on things that in their experience have actually worked well in a concrete situation. What has driven a partnership between sectors, or specifically between health and another sector, in order to address this huge challenge? Thanks.
So I'll invite the panel to think on that other question, but Witjarn, please.
Okay, thank you very much. In Thailand, at that case, I already give you some picture. I would like to maybe elaborate on the CSC Thailand Business Council for Sustainable Development that we are right now. We have member all together is like a big company in Thailand. 40 company work on the issue of the environmental and social. Since they are already work on the issue of the economic, how to balance social and environment. I think it's very important because each company, they have their own, how they get to the sustainable development goal, and climate change also coming. They set their own net zero, but how to work together is very important. Just why our institute, Thailand Environment Institute, we have select from the group to serve as secretary of the organization Thailand Business Council for Sustainable Development. They contribute a budget to us. We set the we call council committee to set agenda. This year, what the issue we are going to work to support the government sector for example, and at the same time, in the case of PM 2.5. For example, currently we are facing in Bangkok and metropolitan area, and our committee set up. We have to leading organization, especially we set the like work anywhere. We can work anywhere, not come to the office. That we can reduce the traffic. At the same time, can reduce emission of PM 2.5, for example. And many activity we have set for the plastic waste management or something like that. Come with the council. The representative of private sector, we have the goal and work closely with the national government agency.
We'll look forward to your progress going forward. Thank you.
Thank you.
Thank you.
Yeah, for the second question, just to cite an example at the community level, when the Mary Johnson Hospital in Tondo, one of the most crowded part of the Manila, when the hospital audited its waste, they found out that the biggest among the medical waste, supposedly, in terms of volume, is food packaging and PET bottles. So what they did with the PET bottles is that they gave away this portable, reusable water container to all the staff, such that they don't have to rely anymore on buying water from plastic container, and put up the water that is made available for drinking across the hospital. What they did with the food packaging, because they are all branded, is to talk with the different food stalls and food shops, including McDonald's, outside of the hospital, and explain that we are discouraging plastic to be brought to our hospital, and if you can please change the way you package your own food. And they did the same to the other food chain. And the behavior has been changed both by the staff, by the public, those who are visiting their own relatives or patients in the hospital, and it's also put up into the policy of on waste management within the hospital. So the collaboration there is not only within the hospital, but among the private food businesses in the hospital. And this was learned by the city, and the city began studying it as a case in point. So that's how collaboration works at that level. And we wish to bring this upscale this in the succeeding work on waste management per se. Thank you.
Thank you, Ramon. Any advances on changing the behavior of McDonald's on its polluting activities must be documented and broadcast. Even if it's just in the vicinity of one hospital, it shows it can be done. So everybody, please take note there. Modi.
Yeah, thank you. I guess I can give an example from a funder perspective. One of our, I guess, pilot investments in climate a few years ago involved us partnering with climate funders to actually start funding, first of all, to pool our funding together so we could fund campaigns that were developed to help advance a shift towards sustainable, healthy diets in Europe. Reducing meat is one of the ways in which you can both have climate benefits, as meat is one of the biggest sources of greenhouse gas emissions, but then also healthcare benefits in a place like Europe where intake levels are probably twice as high as they should be. But it's one of these, it's seen as a kind of a slightly politically toxic area where a lot of governments are actually scared to tackle meat reduction, both because of people's, I guess, cultural attachment to the food, but then also because of the big agribusinesses behind the sector. And so what we did was to think about how can we jointly fund civil society organizations who have experience of campaigning on the food issues like obesity and junk food, together with environmental groups who for many years have had no success in getting support for the climate reduction initiatives, to campaign together in order to help advance, increase awareness, support for getting policies that could help reduce this particular area of food, improve this particular area of the food system. So that in us collaborating to co-finance this, health and climate funders, that enabled civil society organizations who had wanted to partner but didn't have access to funding, would only be funded by a health funder to do health things or climate funder to do climate things, to actually collaborate and co-create campaigns. So it's at the beginning of that, the campaign initiative is still at the beginning, but that collaboration across funders from different sectors has led to the establishment of a pooled fund and increased collaborations amongst the civil society advocates from different sectors. So that's the way in which you can kind of start to stimulate action in this space.
Thanks, Modi. Yes, Kurski.
Okay. Okay, I think as a collaboration with the these sectors and healthcare, they doesn't have to change very much. But the point is that we should have the numerical target and the goal for the collaboration. Because even though any collaboration, maybe such the collaboration will help to reduce carbon emission, but we should check whether that collaboration is enough to attain the carbon neutral by 2050. Time is very limited. Yeah, therefore, from now, when we have to collaborate, we should make anyway numerical target until when, how many carbon we should reduce through the collaboration. Once that having a goal, maybe we can check that the gap, the real situation, and our ambitions every year. Then we will realize what the other sectors should be included in the collaboration. Probably without, I think, a finance scheme, it will be very hard because just the voluntary activities is very much limited to make a big difference. Yeah, and therefore, once they are having such target, maybe we can find the critical partners to be included.
I think that's an important point about the idea of shared goals and then rather than having one sector have to pick up its own sort of feel it's acting in isolation, that there are shared objectives, and actually there's benefits of the collaborative experience, and they need to be defined and valued in the management and governance of these interactions. Hi, Rudolph, isn't it?
Yeah, thank you very much. I'm Rudolph from Ghana. My question goes to the speaker from Healthcare Without Harm. Coincidentally, every green hospital I have seen, it's either a tertiary hospital or a specialized hospital. I am very interested in knowing the experiences from you at the primary healthcare level. Are there initiatives going at this level, and how has the response been like? Thank you.
Let's take the other questions. Liz, morning.
Sure. Thank you. Good morning. My name is Elizabeth Ployce. I'm with the U.S. Agency for International Development. And my question is for our colleague from Japan. And you actually just touched on this, but I was wondering, first, thank you for the presentation. The deep way you examined the sources and drivers of greenhouse gases in the health sector was really very illuminating. I was especially interested in one of the last slides that broke down the demands, drivers, and sources of greenhouse gases and looked at some policy options. I was wondering if you saw any opportunities for collaboration with other sectors or other ministries, especially urban planning or transport or environment, especially as it impacts one of the demands, the illnesses themselves.
Thank you. I'm Alfredo Coro. I'm part of the community that was hit by Super Typhoon Rai. And to highlight the discussion this morning, focused mostly on green hospitals, I'd like to expand the question by a good friend from Ghana on how primary healthcare, which is the first point of contact of healthcare, has to be included in this conversation about how to reduce carbon. Because as our good speakers have mentioned, health can become a very good driver of a community, of how it responds to all these climate concerns. And if we maximize the power of messaging of climate, then all sectors of that community, of that local community, will respond. So in terms of addressing primary healthcare delivery, you are able to expand the influence of how every other actor in the community would participate in the process of collaboration. So just like to highlight a case in point of our experience in Rai, the last super typhoon that hit this region. So with that super typhoon, it's already mentioned about the impact of the typhoon on the Apex Hospital, but what is not mentioned is the impact on primary healthcare facilities that totally devastated the area. And since it was during the time of COVID, imagine how you will be managing, how you will be mobilizing people with the risk of getting infection at a time when there's no healthcare facility available at all. So my question is, instead of talking about, because this is a mitigation discussion from my understanding, so how do we mitigate the response to potentially more intensified storms that we are experiencing? In our region, it's typhoon. In other regions, it's hurricanes. So you have to respond to that. And the new impacts of climate, like post-typhoon, what we experienced was too much heat. And those people that were trying to recover from the effects of the typhoon or the intensified climate storm had heat strokes. And our fishermen died trying to secure food. And I think that's a health issue. And just recently, one year after we experienced super typhoon, we had La Nina. It's still ongoing until now. I think will last until April. So we had flooding, and we had fungal infections and leptospirosis and all the other diseases that we were trying to figure out how to handle. Especially if you're in an island economy, wherein bringing in health resources are your next challenge to climate, because you cannot bring in boats because of rough seas. You cannot bring in planes because of cost of logistics. And the latest one of which is cadaver management. Never in my lifetime would have I thought that we would be looking at potential reopening of previously forgotten diseases, because now, because of soil erosion, too much rain, many of our cemeteries are vulnerable to exposure, some of which were not properly wrapped when they were having infectious diseases previously. So I think if the panel or PMAC would like, hopefully, to look into these issues, because primary healthcare, especially in the rural communities, might be the new causes of previously already addressed diseases that we might not know, but because of climate, the impacts it's doing to these communities, we might be looking at the re-emergence of these diseases. So how do we now address, given all the resources that we have, to make sure that these are not reintroduced in areas where we are most vulnerable? Thank you.
We'll take the suggestion of cadaver management to the International Organizing Committee for a big theme for the next conference. But it's an interesting element that we need to sort of think about in terms of the interactions between water and land, and also this idea of acute emergencies as threats to healthcare access and systems delivery, as well as ongoing longer-term threats. And of course, they interact with each other. Goma, I'm going to come to you during this round of answers from the panel, but please, any reflections on those questions from the floor? Ramon, we'll start.
Yeah, thank you for the difficult question. Primary healthcare is really a huge issue in terms of greening and much more in mitigating emission from healthcare, but we're doing some work around it, and one was the area that was destroyed by the Typhoon Rai. What we did in the aftermath of the typhoon with the funding assistance from some of our climate donors from the US is we were able to rebuild the roof, the roofing, the walling, and reinstall the healthcare facility, the small healthcare facility system that they have in these hospitals, not only in Siargao, but in other islands impacted by the Typhoon Rai. There is a need to rebuild because, as you just mentioned, right after Typhoon Rai, this extreme heat comes, and then La Nina comes. And these are all climate-related events, and we just need to help out, rebuild it in a way that you build back better, but at the same time, ask the question, is putting up a primary healthcare facility near the coast really a practical thing to do? And yet there's the population that you need to attend to. So the question is a policy question as well that we need to attend to. We went to Cambodia recently and trained maternal health care clinics and their workers under the IPPF. And these are primary healthcare providers. And the main problem is flooding, waste management, and the lack of awareness on climate. And after that, a plan has been, after a 3-day session, a plan has emerged, and we need to follow through. So primary healthcare, whether it is a center, a small facility, or a village level kind of a setup, should be given utmost attention in terms of what you just said, Mayor, about the health impact of climate, as well as resilience, and providing that education, make them aware on how climate is impacting health and the healthcare facilities themselves. But we should multiply this action. As in Healthcare Without Harm, we are a small drop in the entire sea of the needs to do, but we have the tools to share how this could be done. Thank you.
Thank you, Ramon. Goma, are you I don't know where to look. If you have any reflections, please, we'd welcome them.
Thank you, Douglas. Yeah. For us, we are at the initial stage to address the challenge of in the primary health care centers from the waste management and greening them to be well respond for the climate change responses. So as it has been mentioned, most of the primary health centers are not well addressed. The good facilities, those who are responding to the climate change mitigations are at the tertiary level hospitals, even though the numbers are very few. So the main challenge that we have identified when we are coming to identifying the primary health, the health care centers in terms of their readiness is information and data. Even awareness is very far for doing exactly what's needed. So for us, it's not like going deep. This is our initial stage. This is where we start sharing information based on the findings that I mentioned earlier. So in our plans, in our institutional arrangements, in our legal framework revision, we are trying to address those issues. This is what my reflection.
Thank you, Goma, and we'll be working with you to look at those plans and implementation thereof, and learning from the experiences that we're hearing here. We've got 7 minutes left, so if just going down the row with any final reflections on some of the ideas and questions we've been discussing. Modi, do you want to kickstart?
Sure. I was just reflecting on the mayor's just illustration actually of what's happening on the ground in terms of people's experiences, one crisis after another, and yet we're still not having sufficient action on climate change. And I think what we really want to help do is help raise those stories and raise awareness that actually this is happening, and we need to take action because it's going to end up affecting us all eventually. So thank you for sharing that. We'd love to collaborate to think about how we get those voices heard. One of the other areas I didn't cover in my talk, but we're aiming to raise awareness of the climate change and health challenge and solutions at the climate change COP and at other global UN processes, and really diversify the range of voices, evidence that's heard and taken to those fora to help mobilize action and mobilize resources. We're also in regular communication with other philanthropic foundations and development agencies, funders in this space, many of whom are also at the beginning of their journey in tackling climate change and health in an integrated way. Most investments to date have focused just on separate health programming or separate climate or environmental programming. So our peer funders are very interested to hear where they can best tailor their investments to maximize health benefits and climate benefits from their investments. So hearing these stories, generating the evidence to guide not only our own investments, but those of other funders are what we really want to do to help drive this problem. So thank you for the contributions. If anyone else has got ideas, please, do share them with us. And yeah, that's kind of what I'd say.
Thanks, Modi, and it's good to hear this idea of peer funding. And I think different funders have different, in a sense, roles in the knowledge ecosystem of prioritized targeting for funding, integrated financing, so that lesson learning and influence that Wellcome can play. I know you've pushed Jeremy into the WHO, which is another interesting tactic to influence the global health community. But this idea of knowledge sharing and influencing of financing is really important. So thank you. Kyosuke, you want to?
I thought I was
You don't
next.
have to. Norwegian's just, sorry, Ramon's spoken, so I'll.
Okay, yeah, thank you very much. What I want to emphasize is that the consistency to the carbon neutral by 2050, if we want to really get there. Small contribution to the carbon reduction. Of course, installing the new technology, of course, it will contribute a little bit reduce the carbon emission. Of course, putting a solar panel on the building is of course better than nothing. But we should check contribution is in line with the carbon neutral pathway by 2050. Yeah. Then we have to check the consistency such things numerically year by year. Then if it's not enough, so we have to add something, including new stakeholders. Then once we had such roadmap to the carbon neutral pathway, maybe we can find that the key stakeholder to be included. Like of course, steep planning will be critical. Of course, the finance scheme like a bank. When, for example, when the installing a new their gorgeous hospital, at least the state government has to check whether that hospital is in line with the carbon neutral by 2050. But because once they're making such building, maybe that building will be used for the 30 years or 40 years. Therefore, emissions regarding the hospital will be, the stacked. I mean, it's committed. It's called committed emission. We can't change anymore, right? Therefore, the state government has to check the consistency. Also, the bunker, because when we make a new building, maybe that I don't know the very rich one, but anyway, most of the hospital, hospitals need to rent money from the bank. Therefore, when the banks support the finance sectors, when finance sector supports such new initiative, elect them to check whether their planning is inconsistent to the roadmap to the 2050 carbon neutrality. Anyway, therefore, the first thing is to making the pathway by carbon neutral goal by each sector. That's the first step. The more important thing is to setting the air conditioner temperature to 27. Yeah, yeah. That's the first step. Because I saw that many videos during conference, the video related to the what we are doing and the health impact, right? Maybe that when we goes up the temperature a little bit more to 7 degrees, 27 degrees, I think that would be effective for our health. I think, right? Making our body the cold, maybe that will be the source of cause their diseases. Also, then this activity, I'm not talking about this room. All, I would say, the office building, shopping center, they have a chance to include the rise up of the temperature rise. But that small activity can be initiated by the healthcare sectors because everyone may believe the voice of the medical practitioners and professionals rather than just me. Yeah, thank you very much.
Thank you, and thank you for reminding us of the science of internal climate control in buildings and its relationship with efficiency and productivity. This is a question that the private sector has been dealing with for years. Yeah.
One more. But if we do so, the most important thing is that the dress code should be T-shirts. And must item to bring is fun. All right?
Is this JICA's official position as well? I think the climate control, we'll take this to PMAC as well. I know the climate regime has changed dramatically since day one. It seems to have warmed up a little bit. Wijan.
Okay, thank you very much. I would like to conclude, especially we have our global target, our national target. Some country already have like a local authority target or something like that. I would like to recommend the policy, especially the policy maker, how to make the policy based on scientific information policy. I think it's really important since we already figure out the number, how we get there. I think it's really important. And also measurable the step already mentioned by our partner, how we measure our success in each step. I think it's very important. For example, when we set up the criteria for PM 2.5, our targets based on the human health impact. we set the figure number. Even in Thailand, WHO already set the criteria. But how we get there, we have to know what the sort of pollution in the country. Scientific information, I think, is very important. Just why the government put a lot of budget for the research to look for what kind of the primary pollutant for PM2.5, what kind of secondary pollutant, how we reduce that the major source of pollution for both like poison, non-poison or something like that. That come from scientific information. But most important thing is the action on the ground. I think it's really important. Translate the policy based on scientific information, and then action on the ground is most important. Thank you very much.
Thank you. So I think just sort of reflecting on what's been said, we seem to have three interacting challenges here. One is the rising demands on the health sector, the increase in non-communicable diseases. The experiences of Japan are going to be crucial here in terms of an aging population, and the disproportionate energy requirements for NCDs specifically. The rising burden from infectious diseases, of course. I'm reminded of the statistic of 58% of known pathogens known to affect human health. 58% of those are aggravated by climate change. So we are going to see an increase also in infectious disease burden, COVID and other pandemics notwithstanding as well. And then maternal health, of course, the science around understanding the links between heat stress and salination of fresh water and maternal health is a rapidly advancing area. So the health burdens are going up at a time when the demands and obligations of the sector to the health sector to green itself are going up, at the same time that the climate impacts on the health sector itself are going up. So this is an acute challenge. So understanding the interactions between them and how institutions respond is an urgent area of inquiry. So thank you, panel. Thank you, Gurma and Addis, for being up so early. Thank you to my colleagues, Lisa Yang, Mashida Rashid, and Suvi Hurikuri for helping put the session together, and PMAC and your good selves for being here. Just to remind you that this is part one of a two-part discussion, which will continue afterwards, looking at the adaptation question, the flip side of this, but and the interrelations with mitigation. So for those of you who can stand another 2 hours of this stuff, please come back after the break. Thanks very much.